Okay, for the second part of nephrology, uh, we were in IgA nephropathy, which shows presentation of nephritic syndrome with hematuria and hypertension. Okay, it's also known as Burgess disease or mesangial-proliferative glomerulonephritis, MSG, IgA, whatever. Commonest cause of glomerulonephritis worldwide, so this has to be the one. Pathogenesis is unknown. Mesangial deposition of IgA immune complexes, as the name suggests. IgA deposition. Histology, you will see mesangial hypercellularity. That's why the proliferative. Positive immunofluorescence for IgA and C3. So IgA and C3 are the ones. Differentiating between IgA nephropathy and post-streptococcal glomerulonephritis. So which one was post-streptococcal? The one diffuse proliferative glomerulonephritis seen in children, similar to nephritic syndrome actually. So this one was for rapidly proliferative progressive glomerulonephritis. Okay, so here the differences might be, let's see, post-streptococcal glomerulonephritis is associated with low complement levels. Here it's high, right? For IgA it's high because there is deposition of C3 and IgA. Low complement levels. Main symptom in post-streptococcal glomerulonephritis is proteinuria. Although hematuria can also occur. Both can occur, but for IgA it's mainly hematuria. And there is typically an interval between URTI and the onset of renal problems in post-streptococcal glomerulonephritis. So post-streptococcal glomerulonephritis usually is like starting with upper respiratory tract infection, and then that may occur. Rapidly progressing glomerulonephritis. Okay, for IgA nephropathy, the presentation might be young male, recurrent episodes of hematuria, usually painless, sometimes with no renal impairment, typically associated with mucosal infections, sometimes upper respiratory tract infection as well. So this is also common with post-streptococcal glomerulonephritis. Nephrotic range proteinuria is rare, renal failure. Okay, associated with what? IgA nephropathy is associated with alcoholic cirrhosis, celiac disease, or dermatitis herpetiformis. Okay, so this is interesting. And management with what? Steroids, immunosuppressant has not shown to be useful. So like not really useful like in nephrotic syndrome where you can manage with steroids. And the prognosis: 25% of patients develop ESRF. Good prognosis: frank hematuria is good prognosis. And poor prognosis: proteinuria more than 2 grams per day, male, high BP, smoking, hyperlipidemia, ACE, genotype DT. Okay, then going to mesangiocapillary glomerulonephritis. You might be confused as to which one was that. Mesangiocapillary. It was the second nephritic one. IgA nephropathy at first. Now we're going to the nephritic phase now. Mesangiocapillary glomerulonephritis is the nephritic syndrome as well, aka membranoproliferative proliferative glomerulonephritis. And the two types that we remember, okay, may present with as nephrotic syndrome, hematuria, or proteinuria. So it's like mixed up, but mostly it's under nephritic syndrome. Poor prognosis: subendothelial immune deficits cause cryoglobulinemia with low C4, hepatitis C, type 3 cause hepatitis B and C, dense deposit disease, intramembranous deposit of electron dense crystal causes partial lipodystrophy, factor VIII syndrome, decreased serum complement, C3b nephritic factor found in 70%. Steroids may be effective. This one may be a bit complicated because this is actually the same as this, mesangiocapillary or membranoproliferative. Okay, this might be a bit confusing for you sometimes. Okay, without this for now, like the glomerular and nephrotic syndrome, I really suggest you to revise once and again and again and again, so that it gets stuck in your head, because this will keep on haunting you till you have them in your head. Okay, next disease would be next page, going to diabetic renal disease. It's usually classified based on the extent of urine protein excretion as either microalbuminuria or nephropathy. So albuminuria, albumin in urine between 30 and 30 mg per day. Spot urine collection is inaccurate, and therefore urinary ACR is better. So ACR more than 2.5 per millimole milligram per millimole in men and more than 3.5 in women is used to define microalbuminuria. So this is something important. 2.5 for men and 3.5 for women. Earliest sign of diabetic renal disease and predicts increased mortality and morbidity. So microalbuminuria basically shows the earliest sign of diabetic renal nephropathy. Okay, diabetic nephropathy, albumin excretion more than 300 milligram per day. That's a lot. More than 300 milligram per day indicates clinical proteinuria with or without increased creatinine. ACI more than 30 in a spot urine sample is consistent with diagnosis of diabetic nephropathy. Providing other causes have been excluded. Okay, so more severe and established form of renal disease and is more predictive of total mortality and morbidity than microalbuminuria. So diabetic nephropathy is like the established disease of the repercussion of microalbuminuria. Now moving to RTA, renal tubular acidosis, a very important topic that you must focus on. All types of RTA. Okay, this is something important. All types of RTA. Renal tubular acidosis are associated with hyperchloremic metabolic acidosis, so which means chloride will be higher. So in type 1 RTA is basically inability to generate urine, acidic urine, secrete hydrogen in distal tubule. So inability to secrete hydrogen in the urine. So basically here hydrogen remains in the blood, which causes the blood to be more acidic. And this happens in the distal tubule, not proximal. Distal is the other end, proximal is the starting, distal is the end. And hypokalemia is there. Complications include nephrocalcinosis and renal stones. Important. The causes include rheumatoid arthritis, SLEs, Sjogren's, hyperglobulinemia, lithium, and nephritisis. These are mainly rheumatological diseases which are causing this. So you have to keep this as a hint. Okay, type 2 RTA, proximal. Type 2 RTA happens in the proximal convoluted tubule in the glomerulus. What happens is decreased bicarbonate reabsorption in the proximal tubule. So you know that bicarbonate is supposed to be reabsorbed in the proximal convoluted tubule, but it doesn't get reabsorbed, so it leaves the body. So decreasing of bicarbonate makes it acidic, the blood. Hypokalemia is also there as well. Complications include osteomalacia. Causes can be many actually. Fanconi syndrome, Wilson's, cystinosis, hyperparathyroidism, amyloidosis, myeloma. So many reasons of RTA. Drugs and toxicity. Carbonic anhydrase inhibitor, lead, mercury, phosphamide. Treatment would be bicarbonate replacement and thiazide diuretics. Alright, moving to the other type, RTA4. This is hyperkalemic. The first two, RTA1 and 2, were both hypokalemic. This is hyperkalemic. It's not actually a tubular disorder at all, nor does it have a clinical picture similar to other RTAs. It was included in the classification of RTA. Where is it? With a mild normal iron gap. The mild metabolic acidosis due to physiological decrease in proximal tubular ammonium excretion. So this is the reason why it's happening. Decrease in ammonium excretion stays in the blood, causes acidosis. Okay, causes include aldosterone deficiency, hypoaldosteronism, primary versus hyporeninemic, aldosterone resistance, drugs like amiloride, spironolactone, trimethoprim, renal transferrin rejection, obstructive nephropathy. So they are like, the classifications are given here. Location, acidosis, potassium pathophysiology. So type 1 renal tubular acidosis happens in the distal tubule. Acidosis is there, severe, and hypokalemia is there. Reason is hydrogen secretion is what? Decreased. So hydrogen remains in the blood. As we've studied here again, hydrogen remains in the blood and inability to secrete, so it's decreased. And then the next thing that comes up is type 2 renal tubular acidosis, it happens in the proximal tubules. Yes, acidosis is there. Hypokalemia is there, so decreased bicarbonate reabsorption. So bicarbonate leaves the body, causing the blood to be acidosis. Adrenal type 4 will be location adrenal because it's about aldosterone. Mild when present, acidosis mild, hyperkalemia is there. Pathophysiology, hypoaldosteronism, pseudohypoaldosteronism. Okay. Now there's another one, type 3. It's juvenile tubular acidosis. So now what happens is combined proximal distal RTA results from inherited carbonic anhydrous type 2 deficiency. Mutations in the gene encoding this gene enzyme gives rise to autosomal recessive syndrome of osteoporosis. RTA, cerebral calcification, mental retardation. 70% are reported from the region of North Africa. Not very important, just keep in mind. Okay, moving on to the next one would be basically ARF, acute tubular necrosis versus prerenal uremia.